echo Evelyn's comments, so there's a lot that I don't have to say because Evelyn has said it already. So from my standpoint, I'm a specialist. I'm not in primary care, and actually I have a little vignette about that. My father is an internist and practiced for many years, and when I got into medical school, I went to University of Michigan. When my father, he was proud of me, and he said, "I'm glad you're going into medicine." He said, "But I won't pay for your medical school coverage, for your medical school unless you don't go into primary care." And he was very serious. He's like, "Do not go into primary care. It's a dead end." Sorry, Evelyn.
I'm actually a subspecialist. I don't see primary care, but it's different because cardiology is a Medicare-based practice, so we can't afford to.
Right, and it's for a lot of the reasons that Evelyn said, is because of that, because of having a practice that was largely Medicare-based, he actually retired early. He retired, and he loves medicine. My father retired in his 60s. He's 70 now. He still reads medical journals. He still gets phone calls from his patients, and he still does home visits. It is cheaper for him to practice for free for his friends than it was to run his practice. So he retired early. Plus he used to be a grandfather. I am very privileged to practice medicine. I love what I do. I love the practice of medicine because it's in my blood. It's what I was born to do. And I'm very privileged that I happen to have a husband who supports my hobby. So, so I work 4 days a week, and I work long hours. I work till 7 o'clock at night, but I love what I do, and I'm able to be there for my kids, and I'm able to live in the town of Weston because I'm in a dual income family, and I don't have a yacht either. But my experience is similar, but a little bit different in that my fear with this Affordable Care Act, as it's called, is that it's government run. And I'm not anti-government. The government does amazing things for our country and for our people. But I will tell you from my training in medical school, when we worked at the VA, it was how to push papers. And if anyone out there has been in the VA system as a patient, you know exactly what I'm talking about. And by and large, you know, you have bureaucrats, doctors, pushing papers, trying to get things through, and just trying to get you out the door till the next time you come. And basically, I never saw the same patient twice. I was there in my rotation for 3 months, various months. I never saw the same patient twice. Never had a chart. It's a little bit better now with the electronic medical records. And you'd spend about, on average, and I was a medical student, but on average about half an hour with each patient to get nothing accomplished. So that was the VA system. And then I was appalled to find out how expensive the VA system is. And I'm appalled for a couple reasons. I'm appalled because it's a huge waste of government money. And I'm appalled that that's the way we would treat our VA, our veterans. And it's horrible. I've worked in Medicaid clinics. When I was a resident, we've all worked in Medicaid clinics. If you work for a hospital, hospitals take Medicaid. It's part of the stipulation of accepting government funds, is you take Medicaid. Medicaid clinics, 8 o'clock. You get a whole load of about 50 patients, and there's 2 doctors. And they all have 8 o'clock appointments. And they're all irritated because they have 8 o'clock appointments, right? And you see them as fast as you can. Again, no charts. The patient doesn't know why they're there. Sometimes they can't tell you what they did last time. They don't even know why they're seeing you. They don't know that they don't even know what doctor they're seeing sometimes. And this is the challenge. And then of trying to help these patients. So that's the Medicaid clinic. And then they say, you know I can get a pair of shoes for free. Can I just have my prescription for a pair of shoes? So that's what I was doing as a medical student, was writing prescriptions for new pairs of shoes for diabetic patients. You get a new pair of shoes. So that was my experience in the Medicaid clinic. When I graduated from fellowship, they asked me to stay on as an employee of the hospital. And I did for a while. And in that situation, it was very similar to what Evelyn had, where there was this, you were assigned a number for how well you generated revenue. You know, like you're in sales. So, I wasn't a high generator, but my patients liked me, and so it was okay, and it was fine. And again, I have the benefit of being in a double income family, so it didn't affect me quite as much as some of my other peers. But I was working in the city. It cost me $50 a day to work, to go into work. And I had small children, so I came out into community-based practice locally in Norwalk. And this was a practice that had 14 physicians. It was a private practice, and life became more sane, at least from a quality of life situation. But what I saw there was this was a small business. This is a practice of 65 employees, including 14 physicians. And so what I saw there was the business side of things, which is they paid for very good quality insurance for their employees. They paid for 100% of the employees there were there for decades, a lot of them, because the benefits at that practice were so good. And what we saw starting in 2010 was when this, maybe it was a coincidence, but once this plan was enacted, we saw the insurance premiums go up by 35%. And that was for a lesser quality insurance plan, was 35% more. So I think what was happening, and I could be wrong, but I think the insurance companies were anticipating the costs that they were going to have to absorb, and thereby spreading it out early by increasing those premiums. All of a sudden now, the employees were getting upset because all of a sudden they had a deductible. But still the practice, wanting to keep their employees happy, paid that initial deductible. So they covered that $1,000 deductible for all their employees that first year. The second year, it went up another 35%. So, and at this point, the deductible is now $2,500. And the practice said, well, we'll go bankrupt if we keep doing this. So we're going to go, we're going to still stay with this premium plan, this Cadillac insurance plan, so to speak. And we'll continue to pay the $1,000. But for a lot of these employees who make, who don't make a lot, a $1,500 deductible is really very expensive. So it became an issue. So I saw it from the business side of things. And it's interesting, I did a Google search on it, and Scott, you can correct me if I'm wrong, but small businesses is defined as 50 or less. And it's interesting because I believe the practice has cut from 65 to 50 or something. I think possibly, I could be wrong, I'm no longer there anymore, but possibly so they can qualify for some of those tax break benefits. So it has large-reaching ramifications, and that could have been any small business. It didn't have to be a medical business for me to. It just so happened that that was a small business that I was a part of, that I saw. I'm taking a little bit of a different road than Evelyn in the sense that I'm going to continue to practice the way that I'm going to continue to practice, which is I spend a lot of time. I'm very talky. Sorry. And my patients know that, and I think most of them like that about me. I decided to go to a hospital where most of the physicians don't take a lot of insurances. And that has given me the ability to limit the insurances that I take so that I can spend the time that I need to with patients. Some are private pay, some are from these premium Cadillac insurances, which, by the way, I understand starting in, was it 2016? There's a 40% surtax on having a Cadillac insurance plan. So if you decide, you know what, I'm worth it, I'm going to pay more for my insurance plan, you're going to pay 40% tax on that. So all of a sudden, you know, Cadillac is like Bentley. So, but you know, for now, I've sort of aligned myself in a way that allows me to continue to practice medicine the way that I want to practice medicine. I'm very happy with what I do. I love what I do. But I'll tell you a little bit about Medicare, because a lot of my patients are also Medicare, because I deal with a lot of spinal conditions and the aging back. requires a lot of care. And so I'll do these injections, these epidural injections. And the epidural injections, in the last few years, 3 or 4 years, Medicare. So I do my injections under X-ray guidance. It's the only way to do it safely. And I used to get paid for the X-ray piece of it, and I used to get paid for the injection piece of it. Starting about 4 years ago, I think 3 or 4 years ago, Medicare decided, well, since you can't safely do the injection without the X-ray piece, then it should be bundled. Makes sense, except that we're not going to pay you for the X-ray piece. You're still going to get the injection piece, but you won't get paid for the fluoro piece. So my revenue on that decreased. It's okay. I mean, I get reimbursed a fair amount on that, except that the hospital that I work with still charges me a fee for the X-ray piece, like I used to, and I don't get any of that. So it now has actually reduced my reimbursement rate on those injections by about 50% in the end. Now, hip injections, which I do for arthritic hips, I actually lose $26 every time I do it, once I figure it. So I actually pay to do the injection. So I still do them because they're useful for diagnostic reasons and for therapeutic reasons, and I figure it all sort of evens out in the end, kind of. But I do. I pay $26 to do an injection. And it's not really $26 because that doesn't factor in the risk that I take, that maybe the pharmaceutical company is going to have some tainted medication, like the recent meningitis outbreak that everybody's so scared about. So the meningitis outbreak that you guys have probably heard about was referring to the epidural injections. Just so you understand, the reason for the outbreak was not the epidural injection, but the manufacture of the medication that was used, which was a compounding company, not a pharmaceutical company. And part of that mandate was, a couple years ago, the CDC said, each epidural injection has to use a fresh vial of injectate. You have to use a new bottle each time. Well, the bottle's only formulated by the pharmaceutical company in 10 cc vials, so 10 milliliter vials. And I use 2 milliliters. So I have to throw away 8 milliliters each time. And it's a huge waste, but it is what it is, and you do what you have to do in the name of safety for the patient. But what a lot of smaller hospitals and smaller physicians did was they farmed it out to compounding companies like NECC to produce small vials, small single-dose vials, to make it cheaper, because it's very expensive and there's a shortage of this medication that I use. I'm fortunate because I work for a big hospital, a big prominent hospital, so I'm able to get my compound, and it is what it is. I don't need to use a compounding agency, but that's what that outbreak is all about. Everything has consequences. When you institute a policy, there's always going to be some adjustment to it, and it's not always the adjustment that you think it's going to be. So,
It's great, thank you.